Okay, let's unpack this. We are diving deep into uterine fibromyomas, or fibroids, as most people know them.
Yeah, fibroids.
Yeah.
And statistically, they're incredibly common. They're the most common benign growth found in the uterus.
Right. Affecting a huge number of women. The estimates are, what, somewhere between 5%, maybe even 20% of women of reproductive age?
That's right. It's a massive segment of the population. And, because they're so common, people sometimes underestimate how complex they actually are.
That's exactly why we're doing this deep dive.
Mhm.
We're aiming for, well, true professional mastery of the topic.
So not just what they look like clinically, but digging into the intricate cellular stuff, the pathology, the hormonal
The
drivers.
things that fuel their growth, and then the whole decision tree for treatment, from just watching them to the really cutting-edge procedures.
Exactly, connecting the dots, essentially, from the bench science to what happens in the clinic.
And the material we've pulled together, this is the kind of detail gynecologists, researchers, they use this level of stuff, covering everything from their origin, those almost medieval names like womb stones,
Yes, womb stones, we'll get to them.
all the way to things like uterine artery embolization, HIFU, the modern approaches.
And a key thing to grasp right from the start is how slow they grow. It often takes, 3 to 5 years before a fibroid is even big enough to be felt clinically.
Wow, 3 to 5 years. That's slow.
Very slow. And while we often talk about a fibroid, they tend to be multiple. You often find more than one.
Good point. And just so we're all on the same page, terms like leiomyoma, fibroma, myoma, they all mean the same thing, right? These uterine fibroids.
Precisely. They're all synonyms for this common benign uterine neoplasm,
Okay, so let's start at the...
either from the uterine muscle itself, the myometrium, or sometimes from the walls of the blood vessels within the uterus. That smooth muscle origin is key to their structure.
So that's the seed, okay. But what makes them grow? It seems like the environment, particularly hormones, is a huge factor. The sources say the evidence for hormonal dependence is impressive.
Oh, it's overwhelming, really. It centers mainly on two key hormones, estrogen and progesterone.
Right.
And the evidence is mostly clinical observation, but it's very convincing. Think about when they appear. They're extremely rare before puberty,
Okay.
and they generally stop growing, and new ones don't tend to appear after menopause.
Which lines up perfectly with when ovarian hormones decline.
Exactly. That timing is probably the strongest piece of circumstantial evidence, but it goes further. They're often found alongside conditions that we know are driven by excess hormones,
Like what sort of conditions?
like hyperoestrogenism.
Yeah.
Clinically, you see this link when there's also endometrial hyperplasia or abnormal uterine bleeding, AUB, or much less commonly, even endometrial cancer. Plus, we know fibroids can grow quite significantly during pregnancy.
Right, when hormones are sky high.
And also in women using certain types of high-dose oral contraceptives, then after delivery, they tend to shrink back down. It's a perfect natural experiment showing that hormone dependence.
For a long time, estrogen got all the blame, but progesterone's role seems just as important now, doesn't it?
Absolutely. It's moved beyond just association. We have proof now. When you use drugs like mifepristone, which blocks progesterone receptors, the fibroids actually shrink measurably.
Ah.
And likewise, GnRH analogs, which shut down ovarian hormone production, shrinking both estrogen and progesterone, also cause fibroids to shrink. So both hormones are definitely involved. Understanding that dual role is really fundamental.
And looking at risk factors, it seems to point back to sort of lifetime hormonal exposure.
It does, yeah. Things like starting periods early menarche, or having few or no children, nulliparity or low parity.
Why is that?
Well, basically, these factors mean more years of uninterrupted menstrual cycles, more lifetime exposure to those hormonal ups and downs, without the long breaks you get from multiple pregnancies and breastfeeding. That cumulative exposure seems to act like a growth promoter. Hashtag 1.2, gross and microscopic pathology.
Okay, shifting from the why to the what do they actually look like? If a surgeon encounters one, what are the classic features?
They're typically very well circumscribed, clear borders.
Okay.
They feel firm. And if you cut one open, the surface is sort of pinkish white, and it has this very characteristic whorled appearance.
Whorled, like a fingerprint.
Kind of, yeah. It's from the way the muscle bundles are interwoven, and they seem contained, almost encapsulated, because they sit inside something called a pseudocapsule.
Right, the pseudocapsule. That sounds important. It's not a true capsule, is it?
No, it's made of compressed connective tissue and muscle fibers from the surrounding uterus. But crucially, it contains the main blood vessels that feed the fibroid.
Ah, okay. So the blood supply comes through this pseudocapsule.
Yeah. Exactly. These vessels send branches radially inwards into the fibroid. Now, here's where it gets really interesting for understanding what happens inside them.
Okay.
Because the blood supply runs from the outside in, the very center of the fibroid gets the least blood.
Right, the furthest point from the source.
Precisely.
Mm-hmm.
And this lack of blood supply, this diminished vascularity in the core, drives the most common secondary changes you see.
Which is degeneration.
Exactly. Early and frequent degeneration happens centrally. Things like hyaline degeneration, cystic changes, sometimes fatty changes. It's basically a supply and demand problem right in the middle.
Okay, that makes perfect sense for why the center degenerates. But you also mentioned calcification, and that starts at the periphery, didn't you say? How does that work with the same blood supply pattern? Seems counterintuitive.
That's a great point. It highlights how tissue reacts differently over time. Calcification, the laying down of lime phosphates and carbonates, actually does start at the periphery. It seems to follow the path of the blood vessels themselves. The calcium deposits along those vessel walls where the supply was originally strongest, near the capsule. Then it slowly spreads inwards over, well, often decades. It's like a slow hardening process moving towards the less vascular center.
Fascinating. Okay, let's zoom in. Microscopically, what's the signature look?
Under the microscope, you see these dense bundles of plain, smooth muscle cells. They're interwoven, separated by varying amounts of fibrous tissue. It looks benign, quite organized usually. Sometimes you might see areas of more embryonic-looking muscle tissue, too.
Now, you mentioned unusual types earlier. Let's touch on those, especially the really alarming one, intravenous leiomyomatosis.
Right. This one is rare, but quite scary. It's where you have these benign, smooth muscle growths, like polyps, extending into the veins.
Like to the veins.
Yes, typically veins and the broad ligaments around the uterus. Surgeons describe them as looking like worm-like cords that they can literally pull out of the veins during surgery.
Wow. And the danger.
The big danger is that pieces can break off, embolize, and travel through the bloodstream. If a fragment reaches the heart, it can block the atrium and cause sudden death. Pretty serious for a benign growth.
Absolutely terrifying. And the other unusual one.
Disseminated intraperitoneal leiomyomatosis. This involves widespread, small, fibroid-like nodules scattered over large areas of the peritoneum, the lining of the abdominal cavity. Interestingly, this seems linked to high hormone states, like pregnancy or maybe long-term oral contraceptive use. Hashtag tagged 1.3, classification by location, the anatomical map.
Okay, location. This seems to be the most critical factor for symptoms and treatment, right? They all start in the muscle wall, the myometrium.
That's right, but where they grow towards defines their type and their impact.
So what's the most common type?
The majority, maybe 75%, are intramural or interstitial. They stay mostly within the uterine wall. They cause the uterus to enlarge, often symmetrically, but they don't bulge significantly inwards or outwards.
Then there's the type that really causes bleeding problems.
That would be the submucous type, about 15%. These grow towards the endometrial cavity, the lining of the uterus.
Swishing inwards.
Exactly. Because they distort and disrupt that lining, they're the ones most likely to cause heavy or abnormal bleeding. If one develops a stalk, a pedicle, and pushes down through the cervix, it becomes a submucous myomatous polyp.
And that polyp can cause other issues.
Yeah, it can get ulcerated, infected, cause cramping.
Okay. And the final main type grows the other way.
Right, the subserous type.
Yeah.
About 10%. These grow outwards, towards the outer surface of the uterus, the serosa. They often show up as a bossy growth, a lump on the outside.
And these can also develop stalks.
Yes, if a subserous fibroid grows on a stalk, it's called a pedunculated fibroid. And these are the ones at risk of twisting or torsion.
Torsion. Painful. And if one of those pedunculated ones detaches?
It can become a parasitic fibroid if it twists off, loses its uterine blood supply, but manages to attach itself to something else nearby with a good blood supply like the omentum or the bowel. It can essentially get adopted and keep growing there.
Wow. Okay, what about less common locations? Subtle fibroids.
These are pretty rare, only 1 to 4% of cases, and they're usually single. We classify them based on where they are in the cervix central, anterior, posterior, or lateral.
And why does their specific location in the cervix matter so much?
Because the cervix is in a crowded neighborhood. Depending on their position, they can put serious pressure on adjacent organs.
Like the bladder.
Exactly. An anterior one can cause urinary frequency, maybe even urinary retention. A lateral one, especially if it grows into the broad ligament space, can compress the ureter.
The tube from the kidney.
Right. And during pregnancy, any large cervical fibroid can physically block labor.
Now, you mentioned broad ligament fibroids. You said distinguishing true versus pseudo is a mastery point. Explain that.
Okay, this is a really important surgical distinction. Broad ligament fibroids grow within the folds of the broad ligament, which supports the uterus. A true one arises from the ligament tissue itself. A pseudo one is actually a uterine fibroid that has grown sideways into the ligament.
And why is that difference so critical for a surgeon?
It dictates how the ureter and the major blood vessels are displaced. A true broad ligament fibroid typically pushes the ureter and vessels medially and upwards towards the uterus,
Okay.
whereas a pseudo-broad ligament fibroid originating from the uterus tends to push the ureter and vessels laterally and downwards, away from the uterus.
Ah, I see. Knowing that displacement pattern before surgery is vital to avoid injuring those structures.
Absolutely critical. It completely changes the surgical approach and the risks involved.
Okay, let's anchor this in the patient experience. A really important point is that maybe up to half of women with fibroids have no symptoms at all, right? They're found by accident.
That's absolutely true. Many are asymptomatic. But when symptoms do occur, they depend heavily on the location, size, and number of fibroids, just like we've been discussing.
And the number one complaint when there are symptoms is usually menstrual problems.
Overwhelmingly, yes. Menstrual disturbances are the hallmark.
Specifically, menorrhagia, heavy, or prolonged periods. Why are fibroids, especially certain types, so good at causing heavy bleeding?
There are a few reasons, particularly with the intramural and submucous types. First, the fibroid itself increases the overall blood flow, the vascularity of the uterus.
Okay.
Second, as we mentioned, they're often associated with that high hormone environment, which can cause endometrial hyperplasia, a thicker lining.
More lining means more to shed.
Exactly. And third, the fibroid physically distorts the uterine cavity. It stretches it out, increasing the surface area of the endometrium that bleeds during a period.
It's like a triple whammy for bleeding. So if it's pushing inwards submucous or sitting in the wall intramural, that's when bleeding is most likely.
Correct. Those subserous ones growing outwards or pedunculated ones on stalks are much less likely to cause menorrhagia because they're not directly messing with the uterine lining.
Are there other bleeding patterns besides just heavy periods?
Yes. Sometimes you see polymenorrhea periods that are too frequent. That often suggests there might be something else going on too, like pelvic inflammatory disease, PID, or maybe cystic ovaries.
Okay.
And metrorrhagia, bleeding between periods, is most common with the submucous type, especially if the surface of the fibroid gets ulcerated or infected.
It's also worth noting, isn't it, that fibroids often don't exist in isolation. They hang out with other pelvic conditions.
That's a very important point. They frequently coexist with other issues. You often find them alongside adenomyosis.
Where the uterine lining grows into the muscle.
Right, or pelvic endometriosis, or sometimes PID. So the uterus might be enlarged and distorted by the fibroid, but there could be other things contributing to the symptoms too. This really complicates the picture for diagnosis and deciding on treatment. Hashtag tag 2.2, pain, pressure, and fertility impacts.
Beyond bleeding, what about other symptoms? Pain seems common, often described as just a heaviness.
Yeah, a feeling of heaviness or pressure in the lower abdomen is very common, especially with larger fibroids.
But when should pain ring alarm bells?
Acute pain is the big one. You can get spasmodic dysmenorrhea, really bad period cramps, especially with submucous fibroids, as the uterus tries to contract against them. Congestive dysmenorrhea is more of a dull ache, often linked to those associated pelvic conditions like endometriosis,
Okay.
but sharp, sudden, severe abdominal pain. That signals a potential complication. It could be torsion, a pedunculated fibroid twisting on its stalk, or hemorrhage into the fibroid, or that acute red degeneration we'll talk more about.
And one really critical red flag for pain.
Yes. Rapid growth, combined with new pain, especially in a postmenopausal woman, raises the suspicion, albeit rare, of sarcomatous change, of malignancy.
Got it. What about pressure symptoms? It's all about anatomy again, isn't it?
Absolutely. If you have an anterior fibroid pressing forward or a cervical fibroid low down, it's going to press on the bladder. That means urinary frequency, maybe needing to pee urgently, or in severe cases, acute urinary retention.
That often gets worse before a period?
Yes, because the fibroids tend to get more congested with blood then. The most serious pressure effect, though, is from those broad ligament fibroids pressing on the ureters.
Which can back up urine to the kidneys.
Exactly, causing hydroureter or even hydronephrosis. The good news is this is usually reversible if you remove the fibroid and relieve the pressure. Constipation from pressure on the rectum is actually quite rare.
Now, for many people listening, the impact on fertility is a major concern. How significant is that link?
It's significant. Fibroids are thought to contribute to infertility or recurrent pregnancy loss in maybe up to 20% of affected women.
How do they interfere?
It can be mechanical or biological. Mechanically, a large fibroid, especially if it's near the corner of the uterus where the fallopian tubes enter the cornua, could block sperm getting up or block the tube itself.
Okay.
Biologically, if a fibroid significantly distorts the shape of the uterine cavity, it might prevent a fertilized egg from implanting properly, what we call nidation, or it might lead to an early miscarriage.
Or certain types worse for fertility?
Yes, the submucous type, distorting the cavity, is definitely the most implicated. And generally, any fibroid larger than about 1 centimeter is considered potentially problematic for fertility.
Okay, finally in this section, let's circle back to that fascinating mimic, pseudo-Meigs syndrome. Why is this a mastery concept?
Because it's a classic diagnostic trap. It looks exactly like advanced ovarian cancer.
Absolutely.
You have a pedunculated fibroid, usually subserous, and somehow it triggers fluid buildup in the abdominocytes and often fluid in the chest cavity, too, typically on the right side, hydrothorax.
So clinically, radiologically, it looks malignant.
It really does. But the key is the pseudo part. The definitive test is removing the fibroid. If you take out the benign fibroid, the ascites and the hydrothorax just disappear spontaneously. It proves the fibroid was the cause, not cancer. A vital lesson in thinking through differentials.
So fibroids aren't just static lumps. They change over time, often because the blood supply can't keep pace, especially in the middle.
Exactly. They undergo these secondary changes. The most predictable one is atrophy, or shrinkage. This happens naturally after menopause when hormones drop, or after pregnancy and delivery. The fibroid gets smaller, firmer, more fibrous.
And we use that principle medically, right?
Oh.
With GnRH analogs.
We do. Those drugs induce a temporary medical menopause, causing shrinkage. But, of course, the effect reverses when you stop the drug.
And those common degenerations you mentioned, hyaline, cystic, fatty happening in the center, are they clinically a big deal?
Usually not for the patient. They don't typically cause pain or new symptoms. They're more about structural changes within the tumor due to that poor central blood supply. They change how the fibroid looks on ultrasound or MRI or how it feels if removed. But generally, they're clinically silent. Hashtag 3.2, calcareous and osseous changes.
Okay, let's talk about the really long-term change, the one that leads to that memorable name. Womb stones.
Right, calcareous degeneration. This is what happens usually in older women when a fibroid has been there for a very long time, decades maybe. It's the deposition of calcium salts, lime phosphates, and carbonates.
And it starts at the periphery.
Yes, typically starts near the capsule, along those blood vessels, and slowly spreads inwards. The fibroid literally becomes hard, calcified, rock-like.
Hence, womb stones. Can you see this easily?
You can. While ultrasound is standard now, a simple plain X-ray of the abdomen will often show this calcification very clearly, especially the peripheral pattern. It strongly suggests a long-standing fibroid.
Okay, if those other degenerations are quiet, red degeneration is the opposite. You said this is an acute, painful emergency, and this is where it gets really interesting diagnostically.
Absolutely. It's most common during pregnancy, often the second trimester, probably due to rapid growth and vascular changes. But it can also happen outside of pregnancy, especially in larger symptomatic fibroids, often in women over 40.
How does it present? What does the patient experience?
It's usually quite dramatic. Severe localized abdominal pain right over the fibroid. The tumor itself becomes very tense and tender to touch. Often there's a fever, maybe nausea, vomiting. The patient feels acutely unwell.
And the name red degeneration comes from its appearance.
Yes. If seen during surgery, the fibroid has this distinctive, almost purple-red color. And bizarrely, it can develop a fishy odor.
A fishy odor, why?
It's thought to be due to the breakdown products. The underlying cause isn't infection, though. It's aseptic necrosis tissue death. Blood pigments leak out from thrombosed, clotted blood vessels within the fibroid and its capsule, causing that intense discoloration. Histology shows thrombosis, but no bacteria.
Given the acute pain and fever, the differential diagnosis must be crucial here. What does it mimic?
It can look a lot like other acute abdominal emergencies, appendicitis, a twisted ovarian cyst, kidney infection, pyelitis, or even placental abruption in pregnancy.
So how do you tell the difference?
Careful history, pinpointing the tenderness directly over a known fibroid mass, and ultrasound findings consistent with degeneration within the fibroid are key. The goal is usually conservative management rest, pain relief, rather than rushing into surgery for what is ultimately a self-limiting process. Hashtag 3.4, malignancy and torsion.
Let's tackle the big fear, cancer. How often does a fibroid turn malignant?
It's extremely rare. The risk of sarcomatous change is less than 0.5%, maybe slightly higher potential in intramural or submucous types, but overall, very low.
And it's mainly a concern in older women.
Yes, almost never seen under 40. It's primarily something to consider in postmenopausal women.
For the listener aiming for mastery, what are the specific red flags that should make you think sarcoma instead of benign fibroid?
3 main clinical signs. First, sudden or rapid growth of the uterus, especially after menopause. Second, new onset of pain associated with the fibroid. Third, any postmenopausal bleeding.
And pathologically, if it were removed, how does it differ?
A simple fibroid is firm, pinkish-white whorled. A sarcoma looks different, often yellowish-gray, areas of hemorrhage or necrosis, and crucially, its texture is soft and friable, crumbly, not firm.
And the capsule?
This is key. The sarcoma is non-encapsulated. It invades surrounding tissue. Benign fibroids always have that pseudocapsule. Sarcomas are highly aggressive and tend to spread through the bloodstream.
Okay, and the other acute complication is purely mechanical, torsion.
Right. This is when a subserous pedunculated fibroid 1 on a stalk twists on that stalk.
Cutting off its blood supply.
Primarily, the venous drainage gets cut off first. This causes the fibroid to swell rapidly with trapped blood, becoming engorged and edematous. This leads to sudden, severe abdominal pain.
Can anything else happen with torsion?
If the twisting is slow or partial, it might cause chronic inflammation and adhesions to nearby structures. This is how it could potentially detach completely and become that wandering or parasitic fibroid if it finds a new blood supply. And very, very rarely, the entire uterus itself can twist on its axis, causing similar acute symptoms.
Okay, moving into how we diagnose these. What can a clinician learn just from a physical exam?
On abdominal examination, if it's large enough, you might feel a mass rising out of the pelvis. It typically feels firm, and the surface can be smooth or irregular and bossy.
And mobility?
It should usually be mobile from side to side, unless it's really huge or stuck down by adhesions, or if it's one of those broad ligament types which can be quite fixed. A Seitz fluid in the abdomen is rare, unless you have that pseudomeg syndrome.
And the bimanual pelvic exam? What's the key finding there?
The bimanual exam confirms it's connected to the uterus. You'll feel an enlarged, often irregularly shaped uterus. The critical sign is that the mass moves with the cervix when you move the cervix.
That distinguishes it from an ovarian mass.
Generally, yes. An ovarian mass usually feels separate from the uterus and cervix. There are exceptions, like pedunculated fibroids, but uterine connection is key.
What if it's a cervical fibroid?
Then the body of the uterus feels like it's sitting on top of the fibroid mass, sort of perched up there.
And if it's a myomatous polyp sticking out of the cervix?
You'll find the cervical opening, the os is open, and you can feel the smooth, firm lower part of the polyp protruding. You might not be able to feel the top of the uterus, the fundus, properly if the polyp is large or causing some uterine inversion. #tag 4.2, essential investigations and modern imaging.
Okay, beyond the physical exam, imaging is essential. Ultrasound seems to be the first port of call.
Absolutely. Ultrasound, particularly transvaginal ultrasound, is the mainstay. It's great for confirming the presence of fibroids. They typically show up as well-defined, rounded tumors, usually hypoechoic, darker than the surrounding muscle.
Can it show degeneration?
Yes, if there's cystic degeneration, you'll see fluid-filled spaces within the fibroid. Ultrasound is excellent for counting them, measuring their size, and mapping their location intramural, submucous, subserous, all vital info for planning treatment.
But you mentioned a key limitation.
Right. Standard grayscale ultrasound cannot reliably tell the difference between a benign fibroid and a rare sarcoma. That's a crucial limitation to remember.
So how do we get around that, and how do we tackle that other tricky differential adenomyosis?
This is where adding Doppler ultrasound comes in. It looks at blood flow patterns, and this is a real mastery point for distinguishing fibroids from adenomyosis.
Okay, what's the key difference in flow?
With a fibroid, the blood flow typically surrounds the mass. The main vessels are in that pseudocapsule, sending branches inwards. With adenomyosis, because it's endometrial tissue diffusely infiltrating the muscle, the blood flow looks scattered throughout the affected area, not confined to the edge.
That's a really clear distinction. What if you need even more detail, especially about potential malignancy?
Then the gold standard is MRI magnetic resonance imaging.
Why MRI?
MRI gives much better soft tissue detail. It's considered the most accurate imaging modality overall for pelvic pathology. It's superior for definitively diagnosing adenomyosis, differentiating it from fibroids, and Critically, it's the best imaging tool we have for assessing features that might suggest a sarcoma before surgery.
Is it useful in other situations too?
Yes, very helpful when a pelvic exam or hysteroscopy might be difficult or impossible, for example, in women who haven't been sexually active, or in older women where the cervix might be narrowed. Stenosis.
What about actually looking inside the uterus?
For that, you need hysteroscopy. A small camera is inserted through the cervix to directly visualize the uterine cavity. It's the best way to see submucous fibroids or polyps.
HSG.
Hysterosalpingography, injecting dye and taking x-rays, can also outline the cavity to show submucous fibroids, and importantly, in infertility cases, check if the fallopian tubes are open. And we can't forget DNC.
Dilation and curettage. When is that absolutely necessary?
It's mandatory for any woman with fibroids who presents with abnormal uterine bleeding, especially intermenstrual or postmenopausal bleeding. You have to sample the endometrial lining to rule out a coexisting endometrial cancer. Remember that 3% association in women over 40 due to the shared hormonal link, hashtag 4.3. The challenge of differential diagnosis.
Okay, fibroids can clearly mimic other things. Let's run through the main diagnostic challenges, the things you absolutely don't want to confuse them with.
Right. The list is quite long. Obviously, you need to rule out pregnancy early on. And hematometer-trapped blood in the uterus is usually straightforward to diagnose. The trickier ones involve other pelvic masses.
Like chronic PID, pelvic inflammatory disease.
Yeah. Chronic PID can cause pelvic masses, often tubo-ovarian abscesses, but usually these masses are tender, often fixed due to adhesions, and the uterus itself might feel normal-sized, whereas fibroids typically make the uterus enlarged and irregular, and they aren't usually acutely tender unless degenerating.
And that recurring differential, adenomyosis versus fibroids.
Clinically, it can be tough. Adenomyosis often presents with a more uniformly enlarged, boggy, tender uterus, maybe around 12 weeks size. Fibroids tend to cause more irregular enlargement, often larger than 12 weeks, and aren't typically tender. But symptoms overlap significantly.
So imaging is key again.
Absolutely. Doppler ultrasound showing that flow pattern difference, or MRI, is often needed for definitive diagnosis.
What's the most serious potential diagnostic error?
Mistaking a malignant ovarian tumor for a uterine fibroid. This is especially a risk with pedunculated subserous fibroids that might feel separate from the uterus.
Or with pseudomag syndrome.
Exactly. Given how serious ovarian cancer is, if there's any doubt after clinical exam and imaging, you might need to proceed to surgery, maybe a laparoscopy, or even laparotomy just to be absolutely certain of the origin and nature of the mass. You cannot afford to miss an ovarian malignancy.
We also mentioned endometrial cancer coexisting.
Yes, always rule that out with sampling if there's abnormal bleeding.
Any other rarer lookalikes?
Occasionally, things like a bicornuate heart-shaped uterus or a chronic ectopic pregnancy that's formed a pelvic mass, hematocylae, or even a pelvic kidney could be confused on initial exam. But ultrasound and other imaging usually clarify these quite easily. A pelvic kidney, for instance, would be fixed behind a normal-sized uterus and confirmed with kidney imaging like an IVP or ultrasound.
Okay, let's talk treatment. It's clear not every fibroid needs intervention. When is it safe to just watch and wait?
Expectant management, or watchful waiting, is perfectly reasonable for small fibroids that aren't causing any symptoms. The key is that you're confident it's benign.
How often do you monitor?
Usually regular checkups, maybe every 6 months or so,
Yeah.
often with ultrasound just to track any growth. But you have to counsel the patient properly.
Counseled about what?
A younger woman needs to know that fibroids might grow during a future pregnancy, and there's that risk of red degeneration. A woman approaching menopause needs to understand that if she considers hormone replacement therapy, HRT, her fibroids could potentially start growing again.
Okay. If symptoms do need treatment, what are the goals of medical therapy?
Primarily 2 things. Manage symptoms, especially bleeding and anemia, and sometimes shrink the fibroids, usually as a bridge to surgery or another procedure.
So first step is often correcting anemia.
Absolutely. Iron therapy is crucial if heavy bleeding has caused anemia. For bleeding control itself, the Mirena IUD, the hormonal coil, can be very effective for menorrhagia, but mainly if the uterus isn't too large, generally less than a 12-week pregnancy size, so the cavity isn't too distorted.
What about drugs aimed at shrinking the fibroids? Mifepristone.
Yes, mifepristone, the anti-progesterone drug. At low doses, say 5 to 25 milligrams daily for about 3 months, it can often stop periods completely and shrink the fibroids by up to 50%. It directly targets that progesterone dependence.
And the other main medical shrinkers are the GnRH analogs.
Right. GnRH agonists are the heavy hitters for shrinkage. They can reduce fibroid volume by 50% to 80% over about 3 to 6 months.
Why use them? What's their main role?
Their main role is usually preoperative. By shrinking the fibroids and reducing their blood supply before surgery, like myomectomy or hysterectomy, they can make the operation easier, potentially allow for a smaller incision, maybe even enable a minimally invasive approach instead of open surgery.
And they help with anemia, too.
Yes, by stopping periods, they allow time for the patient's hemoglobin level to recover before surgery, making the operation safer.
But they have significant downsides, right? You can't use them long-term.
Definitely not long-term. They're expensive. They induce menopausal side effects, hot flashes, vaginal dryness, mood swings, and the big one is bone loss osteoporosis risk if used for too long. That's why treatment is usually limited to 6 months maximum.
And the effect isn't permanent.
No. Once you stop the GnRH analog, the ovaries wake up, hormones return, and the fibroids typically regrow, sometimes quite quickly.
Do they cause any problems for surgeons later?
They can, actually. While they shrink the main fibroids, they can also make tiny seedling fibroids almost invisible. If the surgeon misses these during a myomectomy, they'll just grow back later, leading to recurrence. Also, sometimes the GnRH treatment can make the capsule around the fibroid thinner and more adherent, which can paradoxically make the surgical removal and nucleation a bit more difficult.
Are there newer medical options on the horizon?
Yes, research is ongoing. Aromatase inhibitors like letrozole work by reducing estrogen production within the fibroid tissue itself. And there's a lot of interest in selective progesterone receptor modulators, or SPRMs, like ulipristal or asaprisnol. The hope is they might offer good shrinkage and bleeding control with fewer systemic side effects than GnRH analogs. #tag 5.2, non-surgical and minimal invasive procedures.
Now, for someone aiming for mastery, the minimally invasive field is evolving fast. What really stands out to you here?
The big shift is towards procedures that avoid major surgery, especially for women who want to keep their uterus. Uterine artery embolization, or UAE, has been huge since the 90s.
How does UAE work?
An interventional radiologist threads a catheter, usually through the femoral artery in the groin, up to the uterine arteries that supply the fibroids. Then they inject tiny particles.
Particles? Like what?
Things like PVA, polyvinyl alcohol, gel foam, or tiny metal coils. These block the arteries, cutting off the blood supply specifically to the fibroids.
Starving them,
Yeah.
essentially.
Yeah.
And the results?
Pretty good for symptom control. You typically see about 50% volume reduction at 3 months, maybe 75% by a year. It's particularly effective for relieving heavy bleeding, maybe 80-90% success rate there, and also helps with pressure symptoms. Best suited, generally, for women who finish childbearing and whose main problem is bleeding.
But patient selection is critical.
Right.
What are the absolute contraindications for UAE? Who should not have it?
This is crucial. It's contraindicated for subserous or pedunculated fibroids.
Why those?
Because if you cut off their blood supply, they can necrose, die, break off, and potentially fall into the abdominal cavity, causing peritonitis or infection. Big problem. Submucous fibroids often aren't fully treated by UAE. They might still need hysteroscopic removal. Calcified fibroids won't shrink because the tissue is already dead, essentially. And importantly, it's generally avoided in women actively seeking fertility.
Why the fertility issue?
There's a risk of the embolic particles damaging ovarian blood supply, leading to ovarian failure or premature menopause rates. Up to 30% have been reported in some studies. Plus, there's a risk of pelvic adhesions forming after the procedure, which could also impact fertility.
What are the common side effects or complications?
The most common is post-embolization syndrome, intense ischemic pain, cramping, sometimes fever, nausea. Needs strong pain management initially. There's also the risk of infection, the ovarian failure risk we mentioned, and of course, the radiation exposure during the procedure.
Okay, moving to something even less invasive. MRI-guided focused ultrasound, or HIFU.
Yes, HIFU, sometimes called MRGFUS. This is truly non-invasive. No cuts, no needles inside the body.
How does it work?
It uses high-intensity focused ultrasound beams, precisely guided by real-time MRI, to heat up and destroy the fibroid tissue. The beams pass through the skin and focus on the target inside, heating it to around 55 degrees Celsius, causing thermal ablation.
Advantages?
Big advantages are it's completely non-invasive, recovery is very quick, usually no hospital stay, and it seems to preserve fertility well since it's so targeted.
Disadvantages or contraindications?
The main ones are that it doesn't work well on calcified fibroids or fibroids that have already undergone significant cystic degeneration. The ultrasound beams don't penetrate or heat that kind of tissue effectively. It also takes quite a long time in the MRI scanner.
And one more minimally invasive approach, myolysis.
Laparoscopic myolysis involves destroying the fibroid tissue using energy sources like laser, cryotherapy, freezing, or diathermy heat, usually delivered via laparoscopy. It's mostly used for easily accessible subserous fibroids.
All right, let's turn to surgery. Myomectomy, removing just the fibroids, leaving the uterus. This is the key option for preserving fertility, right?
Exactly. It's the procedure of choice for women who are infertile because of fibroids, or for any woman, regardless of fertility, who wants to keep her uterus and the possibility of future pregnancy.
What needs to happen before the surgery? Any crucial prep?
Absolutely. First, if the patient is anemic from bleeding, her hemoglobin needs to be restored iron, maybe GnRH analogs first. Second, especially if there's abnormal bleeding, you must rule out endometrial cancer. Third, ideally, schedule the surgery in the first half of the cycle, the preovulatory phase, when the uterus is less vascular, to minimize bleeding.
And the consent form.
This is vital. The patient must understand and consent to the possibility that, in the event of uncontrollable, life-threatening hemorrhage during the myomectomy, the surgeon might have to perform a hysterectomy to save her life. It's rare, but it has to be discussed.
Okay, let's talk technique for an open myomectomy via laparotomy, abdominal incision. The biggest immediate risk is bleeding. How is that managed?
Hemorrhage control is priority number one. Surgeons use various techniques. Often, a clamp, a special myomectomy clamp, or a rubber tourniquet is placed around the lower part of the uterus near the cervix to temporarily cut off the main blood supply.
Anything else?
Injecting dilute vasopressin, a vasoconstrictor, directly into the uterine muscle around the fibroid before cutting can also significantly reduce bleeding.
Okay, so you control the bleeding, make an incision over the fibroid, remove it. What's the most critical step after the fibroid is out, especially for future pregnancies?
The closure. After you enucleate the fibroid, shell it out of its capsule, maybe using a myomectomy screw to help pull it. And after you've meticulously stopped any bleeding points in the base, you have to close that defect in the uterine wall properly.
How?
By obliterating the cavity with several layers of deep, strong, absorbable sutures like catgut or Vicryl. This multi-layered closure rebuilds the strength of the uterine wall.
Why is that multi-layer closure so absolutely critical?
Because an inadequately repaired myomectomy scar is a weak point. It carries a risk of rupturing during a subsequent pregnancy, especially during labor. Uterine rupture is a catastrophic obstetric emergency. The repair needs to be strong enough to withstand pregnancy pressures.
And adhesions.
Right. After closing the uterine wall, any raw surfaces on the outside need to be carefully covered with peritoneum peritonized to minimize the formation of post-operative adhesions, which could cause pain or worsen infertility.
What kind of results can women expect after myomectomy, fertility-wise?
Studies show pregnancy rates improve significantly, maybe by 40–50% in women whose infertility was attributed to fibroids.
But there's a risk of them coming back.
Yes, recurrence happens in about 5% to 10% of cases over time. This is usually due to those tiny seedling fibroids that were present but too small to see and remove during the initial surgery, which then grow later.
Myomectomy can also be done laparoscopically. How does that compare to the open approach?
Laparoscopic myomectomy is definitely feasible, especially for pedunculated or subserous fibroids that aren't too large or numerous, say, less than 10 centimeters, maybe fewer than 4.
What are the downsides compared to open?
There are trade-offs. Controlling bleeding laparoscopically can be harder because you can't easily apply a tourniquet or clamp effectively. The procedures often take longer. And concerningly for fertility, some studies suggest a higher rate of adhesion formation after laparoscopic myomectomy compared to meticulous open surgery, potentially leading to worse fertility outcomes. Also, ensuring that multi-layer closure is as robust laparoscopically can be technically challenging, and scar rupture, though still rare, has been reported.
And briefly, the other routes, vaginal and hysteroscopic.
The vaginal route is really only for prolapsed submucous polyps, or maybe very small, low cervical fibroids. Hysteroscopic myomectomy is excellent for removing submucous fibroids directly from inside the cavity, often done with laparoscopic guidance to prevent perforating the uterus.
Complications with hysteroscopic removal.
Potential issues include fluid overload from the distending medium used, risk of thermal injury to the uterine lining, and sometimes uterine adhesions scarring afterwards.
Okay, so when myomectomy isn't appropriate or desired, the definitive surgical solution is hysterectomy, removal of the uterus. When is this typically the procedure of choice?
Generally, for women over 40 who have completed their family or have very large fibroids, say uterus bigger than a 14-week pregnancy, severe symptoms like uncontrollable hemorrhage, or if there's suspicion of malignancy, hysterectomy guarantees removal of the fibroids and definitive relief of symptoms.
What are the main types?
It can be done abdominally, either total abdominal hysterectomy, TAH, removing uterus and cervix, or subtotal abdominal hysterectomy, SAH, leaving the cervix behind. It can also be done vaginally, VH, or with laparoscopic assistance, LAVH or TLH.
Why might someone choose a subtotal hysterectomy keeping the cervix? What are the supposed advantages?
Proponents argue it might have a lower risk of injury to the bladder or ureters during surgery, potentially less bleeding, and some believe it may help preserve better sexual function or reduce the risk of vaginal vault prolapse later on, although the evidence for the latter points is debated.
A big question during hysterectomy for fibroids in premenopausal women is what to do with the ovaries.
The general guideline is to conserve healthy ovaries in premenopausal women. Removing them induces immediate surgical menopause, requiring hormone replacement. So unless the ovaries look abnormal, they are typically left in place.
But there are potential downsides to keeping the ovaries.
Yes, there are risks to conservation that patients need to understand. There's about a 1% lifetime risk of developing an ovarian tumor, benign or malignant, later on, requiring another surgery. There's also a small risk the blood supply gets compromised, leading to ovarian atrophy and earlier menopause anyway, maybe within 3-4 years. And rarely, residual ovarian syndrome can occur if a tiny piece is left behind, causing cyclical pain.
Now, technically, hysterectomy can be much harder with certain fibroids, right?
Yeah. Oh, yes. Particularly large cervical fibroids or broad ligament fibroids. They completely distort the normal anatomy. The bladder can be pulled way up, the ureters displaced, the rectum adherent. This massively increases the risk of injuring those structures during dissection.
So what's the strategy in those really difficult cases?
Often, the safest approach is to perform a myomectomy first technique. You carefully enucleate the large, distorting fibroid first to restore more normal anatomical planes and identify the ureters and vessels clearly before proceeding with the actual hysterectomy clamps and cuts. It makes the rest of the procedure much safer. Let's quickly revisit fibroids in pregnancy because it's such an important intersection. As we said, pregnancy often makes fibroids grow, become more vascular.
Making them more prone to those degenerative changes, especially red degeneration.
Exactly. Red degeneration is most common during pregnancy.
If that happens, the acute pain, fever, what's the management during pregnancy?
Strictly conservative, bed rest, adequate pain relief, hydration, monitoring. The goal is to let the acute episodes settle down. Surgical removal myomectomy during pregnancy is almost always contraindicated.
Why? Too risky.
Extremely risky. Massive risk of uncontrollable hemorrhage from the hypervascular pregnant uterus, and high risk of inducing preterm labor or miscarriage. The only real exception might be an acutely twisted pedunculated fibroid causing peritonitis, but even that's very rare.
And beyond degeneration, what other risks do fibroids pose to the pregnancy itself?
The list is unfortunately quite long. Increased risk of miscarriage, preterm labor, the baby being in an abnormal position, breech, transverse, placental abruption, accidental hemorrhage, difficult labor at dystocia, postpartum hemorrhage, PPH, because the uterus can't contract down properly.
Wow.
Increased risk of infection after delivery, puerperal sepsis, and rarely uterine inversion if a large submucous fibroid pulls the uterus inside out during delivery.
Can you do a myomectomy during a C-section if you're already in there?
Generally strongly advised against. Again, the bleeding risk from the pregnant uterus is just too high. It's much safer to close the uterus and plan for a myomectomy later, if needed, once the uterus has returned to its non-pregnant state. Hashtag 6.2, uterine polyps, brief differentiation.
Just a quick side note on polyps, as they often come up in the differential diagnosis.
Right. Uterine polyps are usually benign growths protruding into the cavity. They can be made of different tissues, endometrial, fibroid, which we've discussed, the submucous polyp, adenomyomatous, or even placental remnants.
What's the key thing about endometrial polyps specifically?
They arise from overgrowth of the endometrium, often linked to hyperplasia. They look like soft, pink, single or multiple swellings. The really critical point is that while most are benign, they can undergo malignant change, or malignancy can arise within them.
So removal and histology are essential.
Absolutely mandatory. You need to send any removed polyp for pathological examination to rule out cancer. Malignancy can start at the base or sometimes at the tip, secondary change. Hashtag tag 6.3. Contraception and fibroids. Finally, some practical advice on contraception for women with fibroids. What should they avoid?
Given the hormonal link, combined oral contraceptives with estrogen and progesterone are often discouraged as they might stimulate fibroid growth, although low-dose modern pills may have less impact. Standard copper IUDs are also usually a bad idea.
Why not copper IUDs?
Because they tend to increase menstrual bleeding and cramping anyway, which would just worsen the symptoms likely already caused by the fibroids. What is recommended?
Barrier methods, condoms, diaphragms are always safe options. The source material specifically mentions Centroman.
Centroman? What's that?
It's a non-steroidal oral contraceptive pill available in some countries. Because it's non-hormonal in the typical sense, it doesn't carry the same risk of stimulating fibroid growth, making it a potentially suitable option. And as we mentioned, the Mirena IUD can be good for bleeding control if the cavity isn't too distorted. Hashtag outro.
Well, that was certainly a deep dive, a real master-level tour of uterine fibromyomas. We've covered their hormonal roots in estrogen and progesterone, the critical importance of location for symptoms, and the spectrum of management from watchful waiting and medical options like GnRH analogs or mifepristone,
Through the minimally invasive techniques like UAE and HIFU.
to the definitive surgical approaches of myomectomy for fertility preservation and hysterectomy for cure.
And hopefully listeners grasped those key mastery points: how submucous fibroids impact bleeding and fertility, subserous ones risk torsion, cervical ones cause pressure, and that vital diagnostic clue on Doppler ultrasound blood flow around a fibroid versus diffused inside adenomyosis.
You know, this brings up a really crucial closing thought, something that truly underscores the skill needed in this field.
What's that?
We know fibroids are incredibly common, often asymptomatic, and they frequently coexist with other conditions like adenomyosis or endometriosis. This means sometimes the fibroids might just be innocent bystanders, right? They might be present, but not actually the main cause of the woman's pain or bleeding.
That is precisely the challenge. The absolute core professional skill is figuring out, before you intervene, whether the fibroids you see are truly responsible for this specific patient's symptoms. Because if you do a major surgery like a hysterectomy or an embolization for fibroids that were just bystanders, the patient's original symptoms, caused perhaps by underlying adenomyosis, won't get better.
A critical distinction.
It really is. Considering the significant impact these conditions have on women's quality of life and the healthcare costs involved, getting the diagnosis right and targeting the true cause is paramount. It demands that thorough differential diagnosis and expert use of imaging we've discussed.
A perfect encapsulation. The pursuit of mastery really does mean understanding the complexity, even in the most common conditions. Thank you for joining us for this deep dive.